Good afternoon, everyone. I am Dr. Somak from Barakpur Hospitals. Now, my topic is macular massage, a different technique of secondary closure for failed to close macular holes. Now, the classic treatment for macular hole is vitrectomy with ILM peeling. A newer modification of inverted flap reposition technique was introduced in 2010, but primary closure may not be possible even after effective and sufficient ILM peeling with or without flap reposition. The average rate of hole closure failure after primary surgery is 13.5%. So the primary closure is basically dependent on hole base diameter, the minimum linear diameter or hole diameter, and the hole height. Various complex procedures are practiced to achieve a secondary closure like autologous grafting, amniotic membrane grafting, etc. These techniques are time consuming, requires a long learning curve and special instrumentations. In the current scenario, we tried a different and simple technique of secondary hole closure, the centripetal massaging of the macula. Retinal massage for macular hole was initially described as a co-procedure in primary surgery mostly. The goal was to avoid any complex technique to achieve secondary closure of failed to close macular hole and to yield better visual improvement. So, purpose of this study was to evaluate the efficacy of macular massage in failed to close macular holes and to observe the secondary closure rate of macular holes using the macular massage technique, avoiding any complex technique for a better visual improvement in those eyes. So, the method was, this was a 6 months prospective interventional study, 8 eyes of 8 patients included, durations of the persistent hole after primary surgery, more than 3 months were included, detailed evaluations of demographic parameters like age, gender, BCVA, IOP done pre and post procedure, baseline and final BCVA with visual improvement noted in logMAR clinal decimal scale, EDI OCT with different open hole anatomical parameters observed like foveal status, whether there is atrophy or cystoid changes, presence of everted edges, base diameter and hole diameter. Surgery time also noted. 25 gauge system, 25 plus gauge, 3-port pars plana approach, centripetal macular massage given with malleable silicone tip cannula. Fluid air exchange was completed in all cases with aspiration of maximum fluid through the hole. The classic prone position for 7 to 10 days was maintained. In the results, the mean age was 57.8 plus minus 23.8 years, which is slightly female preponderance. Secondary closure was achieved in 62.5%. The mean baseline BCVA was 0.8, mean post-procedure BCVA was 0.5, and the mean visual improvement was almost 2 lines, 1.9 plus minus 1.4, with a significant p-value of less than 0.002. The mean presenting base diameter was 1033.9, mean baseline hole diameter was 606.8, mean follow-up was 4 months, mean surgery time required was 6.8 minutes, and mean post-op central subfield thickness was noted 122.7. Everted edge was found in pre-procedure in 75% cases. Cystoid changes at hole margin was seen in 62.5. Neurosensory retinal atrophy seen in 37.5. Post-procedure cystoid changes were resolved in all eyes. Mild to moderate foveal atrophy was seen. These are the 2 images showing the type narrow V pattern closure with lost ellipsoid zone and neurosensory retinal atrophy. Another one is showing the same, showing the post-op type 1 or wide V pattern closure with disrupted ellipsoid zone integrity. Failed to close macular hole is a challenging situation. Non-closure can be seen even after good inverted flap technique with sufficient ILM rexis of 3 to 5 days diameter. We found that macular massage can lead to secondary closure of the open hole in almost 62% eyes, which is a quite encouraging result. The visual improvement appears as early as at 1 month, and the maximal visual gain achieved at 4 months was quite satisfactory, almost 2 lines. The previous studies shown its efficacy in primary closure, but the current study utilized macular massage as an alternate to complex secondary procedures for secondary hole closures only. 25 gauge malleable and less traumatizing silicone tip backflash needle used to relax the perifoveal neurosensory retina and approximate the hole edges. Submacular fluid aspirated through the hole during fluid air exchange as much as possible was done for a better tissue approximation. The centripetal massage perhaps relaxed the perihole tissue and migration of cells towards the edge, aspiration of fluid, obliterates the potential spaces. Our result is comparable to closure pattern described by the others, and pre-existing neurosensory atrophy or thinning significantly reduced the chance of hole closure. So to conclude, the present study concluded that macular massage is a safe, minimally invasive, easy to perform technique that avoids complexity surgical procedure for failed to close macular hole. It is a short learning curve with minimal instrumentation and potential of significant visual recovery. Thank you.
Dr. Somak.
Yes, Dr. Manisha, please.
So Dr. Somak, I would beg to differ a little, because before we had the ILM techniques, we used to all try to have the anatomical closure some way or the other, but the problem was that it never resulted in a visual improvement. Even if when you are using a soft tip cannula and you are actually massaging the retina, it surely does result in some kind of an RP atrophy and compromises the visual improvement.
Yes, sometimes, madam, this occurs.
Yeah, so in today's time, I think when we are talking of a free ILM flap, inverted ILM flap, and so many other ways, I would be a little hesitant in today's time to actually opt for this. Yes, it is going to result in an anatomical closure, but I am a little skeptical how much of a visual improvement.
Functional result may not be as good as like the other grafts procedures.
Right.
Yes, ma'am. Actually, this is the my cases are sample size is quite low, so I think I need some more cases to really evaluate the exact procedure, what is actually happening.
Sure.
Also, the second thing that I wanted to add was that in your cases, so when you did this second procedure, which I do agree to Dr. Manisha that aspirating from the hole and is something that we usually don't do now. The other thing is that you didn't restain any of these cases. I mean, did you try restaining and seeing whether there was any ILM left over there or something like that, or that procedure was totally like aborted by you?
No, sir. Actually, in the primary procedure, the whole ILM was sufficiently removed.
But I might be wrong, but the OCTs that you showed had a kind of a ERM and a frilly ERM over there,
Yeah,
which
there
was
could
present.
be some ERM may be there,
Yeah,
but
so
I think
then
ILM was not present there, because I stained before, in some cases I stained before the macular massage, and it showed basically at that zone there is no staining. That means that zone is basically devoid of ILM.
Right, thank you.